Hello, welcome everyone. Welcome to the webinar. This is my first time giving one of these for the InterStim device on this topic, and so it's exciting to have everyone. I'm sitting here at Charleston GI at our office in the north area that we call Carnes, and it's exciting to give this talk. This is an interesting medical development that helps a lot of people, but there's really no commercials for it. Not much is known about it. To be able to discuss it with so many people at one time is fun. Um, so it's about bowel control. Fecal incontinence is another name for it. Fecal staining, fecal smearing. People don't talk about it a lot because it's embarrassing and it's sort of an orphan disease. We'll talk more about that as we go on and why a new development was needed. There'll be some question answer at the end. Encourage you to submit your questions and we'll try to get through all of them. And of course, we're always here for you in person at Charleston GI to see you as a patient. I'm going to try to advance this screen for everybody. Let's see. Oh, there I am. That's me. I'm from Charleston originally. I grew up in West Ashley. Went to high school here, went to medical school at MUSC. Then I trained at Duke, Wake Forest, some training in San Francisco. I worked for a little bit of time in New Orleans, and then I've been back here home where my wife and I are from for about the last 10 years. And I work at Charleston GI with all my partners. So questions, fecal incontinence is an embarrassing issue. It does affect men and women, but it affects women more, probably because women give birth to babies, and that has a big influence on it. Although you don't have to have had a baby or a vaginal delivery to have pelvic issues. It later in life, it becomes more severe, more limiting. People now are very active late into life, and they find that they're limited by bowel or bladder leakage, keeping them from going to church functions, getting a part-time job, going to lunch with their friends, helping care for their grandkids. And a lot of people put up a little bit of urine leakage, but fecal leakage, because of odor and general the unpleasantness of it, will keep people in their homes. And that's really a negative place to be as someone who would like to be outside their home, who has the ability to lead a full life and can't for this one issue. These are some of the questions people might ask themselves. Most people don't talk about it with their doctor. A lot of women are being seen, and men, for bladder issues, but this won't generally come up. This is generally kept to themselves, either because they think nothing can be done about it or they're just too embarrassed to talk about it. And really, it needs to be addressed, and it can be addressed. People shouldn't give up a whole decade or more of a fun lifestyle due to this issue if it can be managed. Women and men of all ages, although typically I will admit tends to be people over 65 and women more common than men, but it can be both. We've been able to help many men as well with the same techniques. And a lot of people, they say 1 in 12 people have it, maybe 21 million in the US. A lot of people will also have dual issues. They'll have either some urine leakage and stool. Although we're gastroenterologists and we mainly focus on the bowel, it wouldn't be uncommon for our technique to help people who have a bladder issue as well, or the person to also have that problem. So what's expected and what isn't? Bowel incontinence is not an inevitable part of aging. Unfortunately, patients and particularly women will put up with quite a bit. You know, they'll have children like, oh, I had a baby, so I'm supposed to leak forever, or I'm aging, so loss of bowel control is just what it is. I'll get this pad and just move forward. It's actually not that normal, and probably at least should be attempts to address it with your doctor before you surrender to it, because a lot can be done. Planning activities around the bathroom is a mild thing. Obviously, everybody does that to a certain extent, but if that owns your life, that's probably not appropriate. A complete involuntary loss of stool, that's terrifying, and that'll keep people even from shopping for groceries. Stool, every time you urinate, you go to urinate and you're like, there's stool in there. How'd that get there? That's not normal and can be prevented. Staining of clothes, things like that. All these things to some extent can be addressed either with the technology that I'm going to discuss with you today or more basic approaches, but at least should be discussed with your doctor. So how does the bowel control work? So what happens is your colon receives waste from your small bowel, things you can't absorb. It comes in liquid into your colon. Your colon is really mainly a dehydrating machine. It takes liquid stool and pulls the water out of it until it is then solid. Then it stores it. When you have enough stool to stretch your rectum, just like you're waiting for urine to stretch your bladder, well, when you have enough stool to stretch your rectum, a signal goes to your brain and says, ping, 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 you need to go to the bathroom. We're full now. That signal should give you plenty of warning and be fairly mild. And you're like, oh, let's just start looking for a bathroom. Give you plenty of time to look around, make a plan, finish an email, wait for church service to be over, something reasonable amount of time. Um, when that signal hits, it closes you have two anal sphincters. It closes one involuntarily to automatically give you continence to help you before you even know it. Your body tries to slam shut one of your sphincters so you don't have an accident. And the other sphincter is under your control. You then go find a restroom, and then your brain then releases both sphincters and you're able to push and have a bowel movement. Things we see in patients where this system's broken down, they get no warning. Their rectum's completely full. They never get a brain signal, and all of a sudden it just all comes out at once. Or little bits seep out at a time, like a Pez dispenser, with no sensation of it. The brain and the rectum haven't communicated at any time. Or they do get a warning, but the warning is so late and so violent that the time to get to the bathroom, even though they generally make it, is terrifying. It's like the most terrifying 30 seconds of their life, and it's happening several times per day. So those are the classic breakdowns you see. And there's analogies with the bladder for this. If anybody's had bladder issues, the same sort of thing happens for different reasons, but to a similar extent. So the good news, there's some conservative treatments and advanced therapies. And really we should always explore and maximize the conservative therapies before we move to advanced therapies. And then the conservative treatments often augment the advanced therapy. So just because we move to an advanced therapy doesn't mean we should stop the basics that we put into play. So what would be a conservative treatment? Diet modification. If you're someone who's lactose intolerant or you drink a lot of alcohol, we should probably adjust those things so that your bowels are more solid to begin with and easier to control and give you more warning, and that's sort of a simple thing. Most people know to avoid foods that give them urgency or looseness, but it shouldn't be forgotten. It is an important thing to look into and discuss with your gastroenterologist. Physical therapy. When I first started training, and first started practicing, I had very little success with some pelvic physical therapy stuff. A lot of it, and a lot of women I talk about sending them there because I was told I should, and they'd been told to do Kegel exercise before and gotten not very far with it, and so it was disappointing. Something's really changed with that. Here in Charleston, we have a lot of wonderful providers of every type, and specifically a lot of physical therapists specializing in the pelvic floor, and I'm sending my patients there, and they're getting what they tell me is impressive results, improving fecal and urinary incontinence and urgency and the ability to evacuate fully. And so I've started making that part of my plan for all my patients, even someone who might go into the advanced therapy I'll be talking about in a minute. I think by strengthening these muscles, they can augment it. It can also help sexual comfort as well. The pelvis does so much, especially in a female. And a lot of changes happen during pregnancy that at first are kind of like a time bomb. You don't notice it much when you're 35, but then as you age and gravity pulls down and tissues become looser, muscles become weaker, all of a sudden a lot of problems prevent themselves. And you're like, where did this come from all of a sudden? It really wasn't all of a sudden. It just feels that way. Bowel retraining, biofeedback, very specific as it has to do with just your stool, sensing pressure in the rectum, reteaching someone what it feels like. Some people have forgotten what it feels like to have a stool or how to push properly, and we can retrain that. And then there's medications. Some people just really need their stool to be harder, and they can hold on to it better. Just like I can hold something solid in my hands better than I can hold water in my hands. If I can make someone's stool just a little bit more solid, all of a sudden they have continence, and that's basic. That can be done with fiber, like Metamucil, and it can be done with certain medicines that dry up or form the stool up. And then the person, sometimes we overshoot, they get a little bit of constipation and whatnot. But for them, they'd rather deal with a little bit of constipation than the fear of an accident or urgency at the wrong time. So those are the conservative treatments. They don't work for everyone. A lot of people have tried these before they see me, uh, but they have to be considered. So what would be an advanced therapy? Um, Minimally invasive treatments. So this is not really done much anymore, but some people who thought they had weak sphincters, there was like a gel. You see these fillers people inject with now. There was a similar kind of filler that they would do on the inside of your anus above like a donut to kind of create some swelling in there to help create some pressure so people could hold on to things. I had several patients have that early in my career, and it didn't really seem to help them very much. There's also people, if they have a torn anus muscle, your anus is supposed to be a circle. If through childbirth or some other accident, it's torn like that, some surgeons might repair it. You very rarely see that. You very rarely see someone repair an anus. Unfortunately, it's very hard to repair an anus properly and not make it overly tight where someone can't go at all, or to ruin the function of it completely. It's a very important muscle that's controlled partly by your brain and partly involuntarily by your unconscious brain. And it doesn't seem to do that well with surgery, but there are some people who have benefited from that. Um, Here's some surgical here. Post, again, some of the things I mentioned, like an anal repair, replacing the sphincter. And then some people, their continence is so overwhelming and untreatable, they'll get a colostomy bag. Now, my experience is patients do not like this. I've had some people that were desperate, and we bring this up, and as desperate as they are, the colostomy is still not something they're looking forward to, and they want other options. So, although I've mentioned that to people before, I have very few takers. So, as far as the most common minimally invasive, I save that for last because it's the point of the whole talk. I mentioned earlier the injection of the filler in the anal canal, things like that. But the one I was really thinking about was this device called the InterStim. I don't know how many people in the audience know about pacemakers. Most people in the family have someone in their family with a pacemaker, and you can see in the top right corner of this slide this kind of classic pacemaker-y shaped device by Medtronic. Medtronic makes a lot of pacemakers, and so they're well positioned to make this device. The idea is that the nerves that control your bowel and bladder, especially the involuntary part of it, the part that your brain that your conscious brain doesn't influence, your unconscious brain does, those nerves run behind your tailbone, um, the third sacral nerve in particular. And it's unclear exactly what happens here, but if you stimulate that gently with electricity, it sort of wakes the nerve up and improves its ability to talk to your brain and to make that pattern of filling your rectum, your brain getting the proper signal in appropriate time, then be able to get yourself to the bathroom and go all works better. It allows the people's rectum to hold more stool if that's their problem. If usually they can't hold it very little before it wants to go, lets them hold a little bit more, the appropriate amount. If they weren't getting knowledge that it was even full, all of a sudden the knowledge is there. If they weren't getting enough time, all of a sudden the time of the knowledge, the time their brain is aware, is moved up, and so they have more time to get to the bathroom. It's a fascinating device. It was first brought out for people's bladder, which I think bladder incontinence is probably more common than even fecal. As common as fecal is. And the way I understand it is patients were coming back to their urologist saying, oh yeah, this has helped me. But that fecal incontinence I never told you about that we never discussed because I was embarrassed, it's gotten better too. And then the penny dropped for physicians that this is something that could help this unmet need. And when I was first approached about doing it, I said, I'll try a few because I have an unmet need. I have patients that I can't improve. I've gotten them fiber and I've given them Imodium, and I've told them to try to use a suppository before they go out to work every day to empty their rectum so it won't happen when they're out and about, all types of things. And their quality of life is still quite low. So I gave it a try, and it's fascinating. It's quite amazing. And unlike the bladder, where some people in the audience may be on bladder medicines, have heard of like Merbetric or oxybutynin or this new one, Gemtesa. There is not a similar thing for the rectum. And honestly, some of those medicines I just mentioned for the bladder will actually constipate people and make the whole problem more confusing. So what's working for the bladders makes their rectum worse. This device sort of cuts through that without being a medicine, without having side effects, without having a monthly copay and pills to pick up from the pharmacy. All of a sudden, their system works more naturally. And it's been a real boon to the practice of GI. The main throwback is that people don't quite understand it. There's no commercials. I mean, the main drawback, there's no commercials for this. And when you first tell, someone that you might put a pacemaker for the rectum. They sort of go, well, pardon me. But it's becoming more and more out there. I think more people have heard of it. And and the nice thing is you don't just go and have one of these put in. There's an in-between stage where we can see if it actually might help you. Um, so here's a little bit more about the therapy. I'll talk about the test where you can know if it'll help you first. But it's a small battery with a small little wire they call lead that goes next to the nerve. It's not painful. When it's on, people can feel the stimulation. They can feel a little sensation in the rectum, not unpleasant. Sometimes in the vaginal area to know that it's actually on, but it's not painful or unpleasant. It's not a shock. We could never help a patient with something that made them feel like they were getting shocked. That would be somewhat absurd. So it's that's some people's fear. That's not a real concern here. The way we do the test, this is a gentleman here having a test right now. So you can know if it works for you before you ever have one put in, is you come to a place like Charleston GI, I would see you. I would talk to you about it. We'd make a recommendation. I would then bring you to our surgery center where we do our colonoscopies and things. This can be done awake and in the office, but because it's procedure with some needles involved, most people prefer to be asleep. With my endoscopy center, we have anesthesia always available every day, all day. And so what I do is I bring the person in, they lay on their front, and they go to sleep with our medicine that we normally use for colonoscopy called propofol. And I use some needles to place these wires. There's two nerves, a left and a right one, a wire or a lead next to each nerve. And then once I find the area, I can tell by testing the electricity that it's in the right place. I tape it on, and then we put this belt on. You can see this gentleman's wearing a belt, and they get a special iPhone, and you go out for 5 to 7 days. This says 14 days. We do about 5 to 7. And you go out and you keep a diary about urgency, incontinence, accidents of both bowel and bladder. And you compare it. You'll come back to me after 7 days, and I just pull that. You can be awake for. You come to the office, I pull the wires off and the tape, and I ask you, how'd you do? And I compare your diary of how you did during the test to a diary of symptoms prior to when we put the device on. And 90% of people tell me that they've noticed a significant improvement, and most would like to consider a long-term device, one that would go under the skin that they could bathe with, swim with, run with, do a decathlon with. It's very, just like people aren't limited with their pacemakers. Someone has a pacemaker under the skin, they do anything they want to do. This is very similar. Once it's placed, you just do anything you want to do. They have some that are rechargeable through the skin, and some that where the battery is replaceable every X amount of years. And that's how we proceed. There's really no complications per se. I know we're supposed to talk about complications. That's always important in medicine, but these little leads are so skinny, these wires. We clean the skin well, and they're in such a short time that I've actually never had a problem. I haven't had bleeding. I haven't had infection. Really, even it's not very painful. People wake up and they don't go, oh, you stuck me with a needle. They're like, oh, you're done. Thanks. And that's it. And we don't get a lot of pain complaints. We call people every day during the 7 days and ask them how they're doing. Do we need to adjust settings, give them advice, get feedback from them? But I can't even remember last time that involves like a complaint, like I'm in pain. I wish I had done this. Most people are very happy they tried it, and don't ever wish they had not at least tried it. Whether or not they go on to a permanent one and decide this fixes their symptoms, what's sort of gratifying this as a physician, we're sort of in the do no harm business. We don't get complaints, and people are like, oh, wow, this was a bad idea. They're usually glad to have tried it. And usually the vast majority go on to want to consider a permanent placement for their symptoms because they're pleased by how things went. If they'd like it and end up getting a permanent one, I usually combine it with some fiber, other bowel health things, usually some exercises for the pelvic floor, and that gets us a long way. I do tend to recommend more to people who have both problems, urine and stool, although this is a stool talk and I'm a stool doctor. Helping two problems versus one is always very gratifying. And so I've been able to help many patients get control of both issues and often go off some bladder medications, which saves them money and side effects like dry mouth and constipation. So MRIs, this is like a little device, and it is MRI safe. They spend a lot of time trying to make this MRI safe. There's a hotline and a card and stuff that explains to radiology technicians what this is and how it is, but it's not going to limit your ability to get future testing if that's a concern. Um, and then, is it right for you if you have significant FI, fecal incontinence symptoms? If you've already tried some lifestyle changes, like what you eat, fiber, maybe even something that intentionally tries to constipate a little bit, and you're not getting anywhere, I would probably move quickly to this. Mainly, I say move quickly to it because it's so safe. It's not like you have this, a lot of times in medicine, you have the basic things which are safe and may not help. And then your next decision is a huge one, like, oh, should I have major surgery? Should I have a hip replacement? Should I have major back surgery and I'll be out of work for 3 months? This is not that kind of decision. The test is not painful. It's short and you get the feedback very quickly and then it's sort of over. So the risk for the patient is very low. As a doctor, I don't know, I'm not an insurance expert and this really not talk about money per se. But one of the reasons is also gratifying is most of the patients I take care of with this problem over 65. And this is one of the rare circumstances where this is covered extremely well by Medicare. So even financially, the risk is not that high for the patients. They're able to try this, not be injured physically or medically, maybe get a big improvement, but also financially not take a hit. It's something they're able to try. It's probably more expensive to try a new prescription than it would be this. And it's all done at a place, our Charleston GI, like one of our surgery centers where people have had colonoscopies or upper scopes, a place that's kind of comfortable and convenient that they recognize. A lot of our patients have been to us for scopes many times. They come to the same place for this. They find it comfortable in a comfortable environment. Um, so here, I think these numbers are pretty true. 89% of people using Medtronic bowel control therapy experience long-term success. I find that to be true. Do they long-term success doesn't mean they never have another symptom again. That's probably asking a little bit much, but do they feel an improvement? That they're glad they did it? They persist with the use of it? Then yes. I think that I find this number to be accurate with significant quality of life improvements. And again, it is safe. Safety is very important in the GI, in all medical space, especially the GI space. Fecal incontinence is not a life-threatening disorder, so we don't want the treatment to be dangerous. In this case, it's very safe. And you could argue safer than taking a pill every day. Pills have more side effects than low voltage electricity. All right, that's me again. It's probably time for questions, you think? I have Jen Nielsen from the company here with me, and she's helping me as my
Hello,
IT.
everyone.
She's my IT consultant.
We have some questions
she's
here in the chat.
Okay.
And then this is your number to call. So people are just saying hello.
We got a couple of highs here. Some people want to know, why have I never heard of this before? Partly is people will tell you, oh, I got my knee done, my guy's the best. People will say, yeah, I mean, they might even tell you, nowadays you can tell if people have had some cosmetic work done. They'll say it's hard to hide. They'll be like, oh, my guy's the best. People usually don't want to talk about their bowel contents, even if they love their doctor and what happened for them. They usually keep that in their pocket, in their inside pocket. You do go home after the procedure. So when I do this, it's almost sometimes quicker than a colonoscopy. I mean, you go to sleep, you just come on an empty stomach. You go to sleep for it. You really don't have to. I could do it awake, but most people like the propofol that we use for colonoscopy and don't mind taking a little nap while I'm poking them with needles. They wake up, kind of bright-eyed, feeling good, and go home with their driver. We ask them not to do heavy calisthenics for that week because we want the leads, the little temporary wires, not to shake and pull out of place. We want them to be in place so they can get a good test. But but they go kind of live a normal life. You have to take like sponge baths that week. You can't take a full shower bath because it is a little electrical wire. So people use cloth, they use sponges and stuff. So usually once I take their wires off, they're really happy to go home and take a hot shower. So that's probably the biggest inconvenience, but even that's very minor.
Right. And I think like with the stimulation, they're not feeling like an electrical shock.
No.
It's like a real tapping, fluttering, tingling. And a lot of people, that feeling goes away like within 15 minutes. And I always explain it like I put my glasses on my head and they're there, but 15 minutes from now, I have no idea where they are. So it's kind of the same kind of feeling.
I would say that's a good analogy. And what it is not a shock.
Yeah.
It is not a shock. Again, we couldn't really use this technology for people if they felt like they were constantly being shocked by electricity. That's not a sustainable treatment for humans. So you can almost guarantee that's not what people are experiencing. We certainly wouldn't let them go home that way, although I've never had that complaint. we go out and talk to the people for an extended amount of time. There's usually someone from the company there to help give some advice and talk. And I've never had someone go, I'm being shocked. That's just not something. They go, I'm feeling a tingle in a place where the nerve might normally feed. The nerve feeds their bladder. They might feel a tingle up front. Nerves also feeds the rectum. Sometimes they feel a tingle in their rectum.
But it goes away.
It goes away.
But here's the thing that I will say, the life change is unbelievable. I mean, from my perspective, talking to people that are homebound, they don't want to go out there embarrassed and they don't want to talk about this. And the next day, like they can't believe like something as simple as this could change their lives.
I mean, 50 years ago, 65-year-olds went nowhere. There weren't that many of them. Nowadays, every 65-year-old out there is going to their groups, going to their church, going to their meeting, running errands, taking care of their grandkids, driving their car everywhere,
right?
Going on their trips and vacations. So it's a few more things.
So someone wants to know, how many have you done? I mean, wow, a lot.
Me, I've probably at this point done 100. I'd like to do more. People get a little anxious when they think about, you're mostly giving this to people over a certain age. When you tell them that's sort of like a pacemaker for the rectum, some people embrace that. Some people get a little scared off. And I'm disappointed for the ones that get scared off because I think they're missing an opportunity to be improved. What are some of the negatives reported to me? Not really. The only disappointment I get is about 1 out of 10, maybe 1 out of 20 don't feel like it did that much, which is about what you saw there. About 90% of people. Yeah. And, I want all my patients to get the most, but I've never, because it is so safe and it's not painful, I've never had anybody say, why did we do this?
Right.
That's just not something you hear. So from a con, I would say no. I think my biggest con is that if you don't fall in the 90% or 80% that gets some improvement, that makes me sad because I want to help every patient.
Someone wanted to know if you only had urine leakage, are you a candidate?
Yes, if you only have urine, I will work with Charleston GI patients that are established to have urine leakage. Again, I'm not a urine doctor, but this is fully approved for urine only. If that's the only problem you had, we could do it 2 ways. I could do the test, and if it worked, send you to a urologist to have the full one implanted, or I could direct you to. We have a lot of this Charleston, so we have a lot of great local urologists. Or if you already had one, we could tap them on the shoulder and say, "Hey, this is something we talked about. Could you consider this for your patient?" And they may go, "Oh, I didn't realize that's something they'd be interested in," and they could perform it. Urologists also do this procedure. So
1 in 6 have overactive bladder with urology issues, and 1 in 12 have fecal incontinence, and 70% have both. So it's really common. It's really common.
I'm not a bladder doctor, but I have to admit I like it for the bladder because I treat a lot of patients for constipation due to their bladder medicines and dry mouth due to their bladder medicine. Right. So if the bladder medicine can be made to go away
and the expense
of the monthly copay, then I feel like I've also helped my patient. So okay. I'm a regular person like everybody else, and I think, man, if I had to go every month and pick it up, pay the copay, and do this, and then worry about, am I going to go to the bathroom that month because it constipates me? Am I going to be dry mouth all the time? I
think we're good. Unless you have any other questions.
No, the questions seem to have petered out, which is fine. So some of the people who participated might do a follow-up phone call with you to check on you and see if you have additional questions. Obviously, you can always call Charleston GI. Someone has here, does bowel blockage matter in this case? It depends what you mean by blockage. There is a type of incontinence where people get so full of stool, it turns into a concrete in their rectum and they'll pass liquid stool around it. And that's a very special incontinence. Usually we try to get rid of that fecal blockage and then gauge your symptoms. It would not be, if you mean by bowel blockage, a history of a small bowel obstruction that's been treated, that wouldn't preclude you from having this as long as you're at the middle of a small bowel obstruction, which usually that means you're in the hospital. So probably not. Insurance does cover it. With private insurance, they want to see you've tried. All insurances want to see, but private's a little bit more of a stickler that you've tried the fiber and maybe some pill type medications. Unfortunately, some of the insurances will request you take Imodium, which Imodium's like a hammer. Mm-hmm. You're trying to treat some incontinence with something that makes someone not go to the bathroom for weeks. So I hate that, but we do have to try to work with our insurance carriers. They also want to see your diary to see how bad your symptoms are, or at least the fact that we got a diary. The Medicare covers it very well. It's sort of surprising how much Medicare has embraced this, and that suits us because a lot of our patients are 65 or older with this. But yes, it is covered.
People are, someone's saying they have success with the device. They're not disappointed they did it, which is great. And people are saying thank you.
Very good. Well, it's great to have everybody. This is fun for me to reach so many people at one time about something that's hard to talk about. We have a number here. You can see it on your screen, 843-408-0371.
This is for appointments.
And there's a little QR code for appointments. And if you're already established at Charleston GI with another doctor, we've all discussed this internally. They're happy for me and one of our other physicians who provide this service specifically to see you about this and handle this for you. If you want to go through your normal Charleston GI physician and talk with them first, that's great. Charleston GI, those are my great partners are always there for you.
And you're here for all of their patients and all of your patients and everyone here who has this issue. So and Dr. Shores is an amazing doctor, and we're just so thankful for this webinar tonight. It helped a lot of people.
Everyone have a great evening. Please don't hesitate to reach out.
Thanks, everyone.
Bye-bye.